So welcome to Georgianne Arnold, who is visiting via Jane DeLuca. And so she is a professor at University of Pittsburgh and also works with the Genetic Metabolic Center for Education. And so she's just passing through, and we asked her to kind of talk about a topic, and this one seemed fairly relevant to most of us in terms of developing practice protocols for genetic and metabolic disorders. So welcome.
Thank you, and I'm happy to be here. And this is actually a topic that's pretty near and dear to my heart. So, evidence versus eminence. This is after the Human Genome Project was announced, as we went through the 90s, they began to realize that they were making a lot of laboratory discoveries and that they hadn't really paid much attention to how these were going to be translated into the clinical arena. So the whole concept of translational research and translational projects got a lot more important, and it led to the development of some of the K30 programs, which were for the development of clinical research training programs, and then the Mentored K Award series. And there are pockets of thought about evidence-based medicine and clinical practice, and kind of began to coalesce into a formal science of the practice of evidence-based medicine. So, through the Medicare Improvements for Patients and Providers Act of 2008, Congress asked the Institute of Medicine to undertake a study to find the best way to develop clinical practice guidelines. And so they developed 8 standards, and they asked the AHRQ, the Agency for Healthcare Research and Quality, to pilot test the standards, and they released their report in 2011. So the first standard was that clinical practice guidelines, the process should be transparent. It should be the funding, the development, it should be explicitly detailed. The second is that the conflict of interest of the people making up the guidelines needed to be disclosed. And they recognized that when you assemble a panel of experts, some of them are going to be conflicted, because that's kind of how they got to be experts, by having research funded. And so the chair and no more than half the committee are supposed to have a conflict of interest on this subject. So how do you pick your group? Well, this is kind of obvious. It should be multidisciplinary and balanced. But what people are forgetting is that the recommendation also was to include stakeholders in at least some parts, like question formulation or draft review. And they recommended that the science groups develop strategies to increase effective participation of key stakeholders, including helping train them to appraise evidence. Then begin with a systematic review of the literature, and there were Institute of Medicine standard systematic reviews of comparative effectiveness research. That's a mouthful. And interestingly, they recommend that the systematic review group and the guideline group be different, which I'm not still sure I quite understand, but that they have to interact with each other. So then you have to look, what is the foundation of the evidence behind this statement of how you should practice? So for each recommendation you make in your practice protocol, you should go through the rationale, the harms and benefits, the evidence, including the evidence gaps and the consistency of the data, the explanation of the opinions and values and clinical experience of your panelists. You should rate the confidence and strength in the recommendation and describe and explain differences of opinion. And one reason why I think this is really important is that clinical practice guidelines are used to judge people in malpractice cases, besides telling you what to do. And if you put a statement out there saying you should do A, and really only 75% of the people in your guideline group said you should do A, I think that there's plenty of room for you to not want to do A. if that's not in your best clinical judgment. And so it is really important when a clinical practice guideline isn't unanimous that the differences of opinion should be described. So the guidelines have to be articulated, and including precisely what the recommendation is when it applies, and that strong recommendations should be strongly worded. Then they recommend external review. They recommend that the reviewers be kept confidential, but comments should be kept in the records. And then a draft of the almost final guideline available to the general public with reasonable notice, so there's room for people to comment. And then updating, they should be updated. And that's the hard part, because it requires time and money to update them. And there really isn't any hard and fast rule about how often should they be reviewed, every 3 years, 5 years, 10 years. And we haven't really dealt with that in genetics at this point. So what are the standards for a systematic evidence review per the IOM? So for the initiation of the review, they recommend assembling an expert panel, managing the bias and the conflict, ensuring user and stakeholder input, formulating the topic, an analytic framework, key questions, and then a systematic review protocol. And you have to really clarify what are going to be your study inclusions and exclusions, your outcome measures, your search strategy, and you may very well need a professional to really help you get a good review. And then making the final evidence review available for public review, so try to publish it. You'll notice if you've looked at things that the Secretaries Committee has done, they publish their evidence review separately before they publish their recommendations on what should come up for newborn screening. So editors are going to have to agree to accept those. And then finding and assessing the data, these are fairly self-evident. Conduct a comprehensive systematic review, address potential bias in the review, call researchers and ask them to clarify something, invite unpublished data. So really try to get as much data as you can. And each research project or principal should use at least 2 researchers independently. And then document your search, how you did it, what you found. And then they recommend a prescribed method to evaluate the evidence, biasy, consistency, precision, decide if a meta-analysis of the data you found is feasible, and then report on the review. And like I said, publish this separately if you can. Great detail on methods, a results section, a discussion section, funding, conflict of interest, peer review, and publish in a theoretical real world in a manner that ensures free public access. So that takes us from the ivory tower into the fire, because that's what the IOM says you should do. But it isn't really that easy in many ways and in many cases to practice in that ideal ivory tower. So if you look at the PKU, was anybody here on the PKU panel? The AHRQ publication of the PKU Evidence Review was in 2012, and they applied such stringent standard to their evidence review that they excluded 97.5% of the PKU literature from the review. So on the one hand, in the ivory tower, you want this perfect review of perfect studies. They had to have greater than 10 patients. They dismissed many key PKU studies for lack of uniformity and methodology that weren't suitable for meta-analysis, and they ended up throwing out most of the literature. So part of what we can learn from that is that we need to develop better literature, but the other part is how good are your clinical practice protocols? Because it's, the alpha and the beta error. The more stringent you make one, the bigger you make the other. And that was a real problem for the PKU study. And clearly, rare invariant errors of metabolism are not going to meet the evidence level needed for any kind of a stringent review. So, particularly in metabolic disease and in most rare diseases and rare genetic diseases, evidence-based reviews are probably not going to get us very far. So, what are we going to do about that? Now, first, we need a way to grade the evidence. So we need to do a better job designing studies so that they'll help us get to the evidence, because a lot of the clinical research studies that are published are done by people who didn't get any formal training in clinical research. And in all honesty, they're not very good, including most of what I published in the years before I got any clinical training research. And particularly in rare diseases, we need a way to develop guidelines even when we don't have evidence. So people still need help treating metabolic patients and rare disease patients, even though we don't have adequate evidence-based studies yet to tell us how to do it. So we need something else. So as far as grading the evidence, there's no single standard recognized way to say how good the evidence is. The Oxford Center for Evidence-Based Medicine, I think, is quite good, but what's now becoming the sort of more commonly accepted is the SIGN network, the Scottish Intercollegiate Guidelines Network, and that's what's being used by the EU, and I'm seeing it more and more appear in the US literature. So they say it's a grade 1, or if it's a randomized clinical trial, and depending on how big the trial is and how rigorously conducted, it can, it's sort of 1 plus, and 2 is not necessarily a randomized clinical trial, but perhaps case control cohort studies. 3, case reviews, case series, case reports, and then 4 is expert opinion. So what people think and the evidence of data. So you take those numbers and you come up with a grade from A to D. This is a grade A recommendation. It's based on randomized clinical trials. Or this is a grade D recommendation. It's mostly expert opinion. So you can take a clinical practice protocol and you can rate it and say how rigorous that recommendation is. So one of the things you have to ask is, what is the quality of our evidence? So if you have 1 randomized clinical trial, is that enough? If you used an alpha of 0.05, a 5% chance that you were wrong. So do you need 2? And how many patients do they need to have? And so sometimes you may, even when there is evidence, you may need some kind of consensus regarding whether it actually is going to meet a grade A. And then consensus regarding how to proceed on managing patients with a clinical practice protocol in the absence of quality evidence. So how do you come to consensus? Well, there are sort of old-fashioned ways, brainstorming. You just take a bunch of your friends or a bunch of experts, put them in a room and say, write some protocols. And that's the way a lot of our protocols are still written. And we can do better than that now. The NIH-style conference is kind of interesting. They select an expert panel, they present testimony, they do an evidence review, and then they all get together and decide what they think. But I think that is going to be going out of fashion as well. The Secretary's Committee on Heritable Disorders of the Newborn is kind of a medley of several of those. And I think they've done a lot of good getting people to, getting the evidence review out, published separately, getting people to sort of understand a clear and open sunshine way of how they come to their ideas. But I think even they probably could even do a little better. Nominal group technique is where you bring groups together, but instead of just brainstorming, it's actually got defined ways to work. Like you say to somebody, I want you to write down your top 5 thoughts on this. And then everybody has to go around and like say their top 5 thoughts. And so it's sort of, you're not waiting for people to just shout out things. Everybody gets a chance to talk, and every idea is listed and discussed. And so it's a way to get everybody in a group to talk, so you don't get like a couple people dominating a group. And then I'm going to talk last about Delphi, because Delphi is something I find absolutely fascinating, and it does seem to be taking over from any of these other. So Delphi was developed during the Cold War by the Rand Corporation for the military, for things like forecasting needs, like, do you think we're really going to go to war with Russia? And how many tanks should we make next year? And how many soldiers should we draft, or volunteers should we look for? And how big do you think the Army needs to be? And things that we didn't really have a good and hard answer for. And so they would bring the decision makers in the military together and decide. And then in the 90s, it began to show up in the medical literature. And interestingly, one of the first places it showed up was in the nursing literature. And it has been used in a number of specialties now. In fact, now like the Psychiatric Association and otolaryngologists now actually have a formal society recommendation for how clinical practice guidelines should be done to get the stamp of approval from their society, and they are Delphi. So how did I get introduced to Delphi? I had a K23, and I took a clinical outcomes research class. No, I'm sorry, this was before I had my K award. It was several years before, but my chair was encouraging me to take some formal methodology research classes. And I ended up taking an outcomes research class, and everybody had to do a project, and everybody did a meta-analysis. And I didn't want to do a meta-analysis. I still don't like a meta-analysis. And the teacher gave me information on Delphi and said, I want you to read this, and I want you to write a paper about it. So I did my term paper on Delphi, and it just sat in the back of my mind for a couple of years. And I was like, I got to use this. I've got to use this, but how is this going to work? How is this going to work? And then when I got the K30, I was sitting in a survey research class, and it was the first class, and they were explaining to us that we were going to have to do a survey as our course project. And my pager went off, and it was another newborn screened for 3-MCC deficiency. And I was like, oh God, what am I going to do with this one? And all of a sudden I was like, I'm going to do a Delphi and ask my friends, and that's going to be my course project. And so it was. And it was published. I got an A in the class. And this was like in 2007. And so it does not currently meet IOM criteria, because this was before these IOM criteria were written, but it was, and actually the panelists really liked it. And they came afterwards and said, they came to me and said, we want to do VLCAD now, because we don't know what to do with these abnormal newborn screens for VLCAD either. And so then we did VLCAD next. That was published in 2008, I think. And there were some interesting reactions to that I'm going to talk about later. And then my grant ran out, and I moved, and I kind of just lost the thread of this. And so these guidelines are not updated. They need to be. But this is one of my hope, is to get back to this. Now, the GMDI have also written protocols, some of which they said are Delphi, and some of them actually are Delphi, and some of them are called Delphi but are not Delphi. But it's begun. It's not just in the nursing and the doctors. It's getting into the nutrition literature now, which is good. So it begins with a clinical question, like, what should I feed a newborn with an abnormal newborn screen for VLCAD deficiency? So you assemble panelists. Originally it was like 12 to 15. Now people are saying more like 9 is optimal. It kind of has to work. So it's in some ways hard, because you want the experts in the field there. You can't have all people who've been funded by, a company that makes something for VLCAD, because then there'll be too many conflicted. But yet you want the experts, and some of them may have been done a formula study for Enfaport, and and so they're conflicted. But many of them won't. With rare disorders, it's maybe a little easier to assemble a panel, and maybe a little harder in some ways. You want people who will put out for you, because I had no money to pay anybody to do this. So, and we're all very busy. So I had to ask people that I knew well enough that they would actually do the work. So you want experts, but you want them to be people you know because they'll do the work, but you don't want to get everybody who thinks just like you, because then you've biased your panel. So this is actually the easiest way to bias your panel, is who you pick to be on it. And it actually is a little bit of work. So you then disseminate the evidence review to the panelists, whether the evidence review is done by the same group or not. It's, I don't necessarily understand exactly why now they're saying the evidence review group should be different, because now you're going to assemble, 30 people to work unpaid on this. I don't think so. So you got to do the best you can with what you've got. And then you make a survey of questions. What do you think about this? And really, an easiest way I think to do this is a quantitative scale, like a Likert scale. Like 1 is strongly agree, 2 is agree, 3 is neutral, and then they pick a response. So, would you stop breastfeeding in an asymptomatic child, a newborn with an abnormal newborn screen for VLCAD? I would stop breastfeeding, agree, strongly agree, and you go through your questions. So also asking the right questions is very important, but hopefully your clinical experience and your evidence review is going to help you to write those questions. So then you take your first set of surveys and you tabulate the response, and you say, this was question 1, would you stop breastfeeding in an asymptomatic baby, blah, blah, and this is what the group average was, and this is what you answered. And so you go through that, and you give them the opportunity to do the survey again. Now, one of the people on my VLCAD panel had not seen the evidence. I guess he didn't read all the evidence review about the acylcarnitine sometimes normalizing on a repeat newborn screen. So that answer changed. So some people will look at that and say, oh, what I think is way out of what other people, what did I miss? They'll go back, they'll look at the evidence review again, they'll change their answer. Some people will say, my clinical experience is different than this group answer. And some people will say, no, I have seen this, I will not change my answer. So between the first and second survey, answers float a little. So do they sometimes regress to the mean? Do they sometimes change? They change some. I'm not sure they change a huge amount, but it actually educates you too. Sometimes if your answer is way off the mean and you have to go back and look at why. And sometimes you learn and sometimes you say, no, those other people are wrong. So after the second survey, you have a face-to-face meeting where you review the areas lacking consensus. So what we did for these was we had our meeting, at our face-to-face meeting at an SIMD meeting, because I didn't have money to pay to bring people together for a face-to-face meeting. So we just stole off for a few hours and had a face-to-face meeting and argued about things that we couldn't agree on. And some we agreed on, some we didn't. And then we did a final third survey. And that is where we got the consensus score from. So, the mean response was a 1.5, which is somewhere between strongly agree and agree, or the mean response was, 3.5 between neutral and disagree. And so you get a score for how well people agree. So this is from 2008. And this is from the VLCAD paper, and so this is before there was Enfaport for the nutritionists in the room. So at this time, the only thing we were lacking 9 years of experience with newborn screening for VLCAD that we now have, and also there was no Enfaport. So all we had to feed these children at that time was Portogen, which is not an infant-based formula. So these guidelines are outdated, but we said if your patient is less than 12 months of age, they're at risk for a fasting intolerance or myopathic phenotype from VLCAD, and they're breastfed, but they're asymptomatic, would you continue breastfeeding? And 93% of people either agreed or strongly agreed, with a score of 1.7, which is 1 was strongly agree, 2 was agree. So it was a fairly strong consensus. And then the next question, would you add MCT supplements beyond the breast milk? No, they didn't think they would. But if this child had ever been symptomatic, would you supplement with MCT? And when I did it, I used 2/3, 67% for consensus. Some of the new ones are using like even 75 or 80% to call it consensus. So I called this consensus. Not some of the guidelines wouldn't. Would you change to a maximally enriched MCT formula? No, they would not. Now, if we did this again today with Enfaport, I think I would probably get a different answer. And that's why this really needs to be updated. Although I've heard some people have had trouble getting Enfaport to dissolve. I don't know if any of you have heard that complaint.
Lipistart.
Oh, use Lipistart. Okay, so now there's Lipistart too. Okay, so yeah, you're right. Yeah. Okay, so
Monogen just added DHA to their formulation.
yeah. Okay. So that's why these need to be updated, because this is old. But if it was a bottle fed, would you change? That still actually didn't quite make consensus to a higher MCT formula. If the patient was over 12 months and asymptomatic, would you change their diet? Yes. What would you use? We tested several diets, and the one that tested best was a heart-healthy diet plus MCT oil. If your patient was already older than 12 months and had manifest symptoms, if they were fasting intolerant symptoms, would you change their diet? Yes. And would you if they had a myopathic phenotype, would you change their diet? So what's interesting is these did not come to 100% consensus, but I think there were clues in there for people on this is what a preponderance of, or even a majority, or a significant majority of your colleagues think. So what's good about Delphi is that it's a standardized process. And it gives you a way to incorporate evidence and consensus-based guidelines. So you can say, we agree that this is grade A evidence that you should do this. And then you can say, but these other things that we don't have evidence for, well, there are some case reports. And so, the case reports suggest that this is grade C evidence that this is a reasonable thing to do. And there's really no significant evidence. This is a clearly grade D report based on a consensus opinion, but we came to consensus that you should do blah, blah, blah. And 93% of the panelists agreed strongly or agreed. So you can clearly identify the grade of the recommendation. So which is evidence-based strong, which is evidence-based weak, which is consensus-based. The surveys are done privately, and so scores are driven by the strongest opinions and less by the strongest personality in the private surveys. Face-to-face, you still have to deal with strongest personalities taking over the room. So a large panel size helps to eliminate some bias. And the extent of the agreement and disagreement can be defined. So there can be some wiggle room. If your clinical experience clearly tells you something's a problem and you don't want to do it, even though it's written in a clinical practice guideline, you at least have some wiggle room and some leg to stand on legally if there's a problem. And it is relatively inexpensive except the face-to-face meeting, which hopefully you can tack on to a national meeting and therefore make cheap. What's not good about Delphi? There's still room for bias, particularly in panel selection. And with the VLCAD, I got a lot of blowback because people said, you didn't tell me what to do. Because there were places where we put questions out there and the group did not come to consensus on what to do about them. And they're like, well, what good are clinical practice guidelines if they don't tell me what to do? But if the group can't agree, they can't tell you what to do. So all we can say is, 61% of your peers who are experts in this field thought that this action was reasonable, but 40% of them would do something else. And so I just don't see how you can publish clinical practice guidelines as absolutes when they're not. And the mean of a consensus score is simply a mean. It is not a scientific truth. Consensus is grade D evidence. So consensus guidelines are better than no guidelines, but they're not truth. And if you need to remember that when you use them. And then managing physicians is like herding cats. Getting 15 busy doctors to fill out 3 surveys is like herding cats. It's a lot easier to do an NIH style where you just lock them in a room and tell them you can't come out till you have a document. So it's, you know, these methods all have their good and bad, but you know, they're not so, none of them are perfect. But what are some of the barriers to this guideline? Time, money, commitment. Time, money, commitment. Time, money, and commitment. So where are we currently? The Society for Inherited Metabolic Disorders has declined to engage in clinical practice guidelines. They have decided that we are too small and don't have deep enough pockets and enough insurance to deal with it. So you will, at least in the near future, not be seeing clinical practice guidelines coming out of the SIMD. However, SIMD members do sit on committees in the ACMG. So hopefully we are trying to use the ACMG. Now, until recently, the ACMG has been using brainstorming and eminence-based approaches. And in like 2009, when I was hot on this Delphi and went to Mike Watson and said, you need to do this, he kind of patted me on the head, really somewhat patronizingly, and said, oh, my dear, we're going to do evidence-based protocols here. And when I said to him, and where's the evidence going to come from? He kind of gave me a blank look. But based on the last couple of committee chairs meetings I've been in, he's getting it now. He's getting that we are going to need consensus-based documents because we don't have any evidence. And the development of these consensus-based documents are also hopefully going to help you drive future research to fill the gaps in the evidence. So what are we going to do to fill in the gaps? Small groups like the GMDI, New England, Rocky Mountain, and you know, some people who just are experts in a certain field and are saying we got to help people out and write some guidelines. They're trying to patch the holes. But there's not a big significant coordination of efforts. And I am now on the, it's not a committee, it's an interest group at the ACMG that is trying to sort of marry the clinical practice group and several of the groups that sort of do this, but nobody seems to know exactly what the other group's doing. We're trying to decide if we're going to become a committee, and we're trying to get Delphi introduced into this committee. And so I'm hoping, but even as a bunch of volunteers, 1 guideline a year would be a lot to come out of a committee like that. And so if we really want to have clinical practice guidelines, we're not really going to be able to depend on the ACMG to do it all either. We're going to have to find some other ways to get these funded and get these done. So where do we go next? I am someday hoping to update the VLCAD. And we really need to get this method out there, to get people to understand it, to stop. I actually just reviewed a clinical practice protocol for genetics and medicine, and it was, they said they did it with Delphi, but they didn't. They sent out a panel of questions. They put on an advertisement saying, if you manage patients with this disorder, come join our survey. And so they sent out a questionnaire to that they called a Delphi survey that wasn't a Delphi survey, and instead of, they assembled an expert panel, but then they didn't give the survey to the expert panel. They gave it to just people who said, are you interested in this disease? So like 54% of the people who answered were nutritionists. So why would you write a Delphi panel and then give it, not use your expert panel? And then they did a nominal group technique to come to guidelines. They didn't quantitate how the consensus, there were just issues with it, so we sent it back. And we really need to do better, and I think we can. I think we can do better. But it would really be nice if the ACMG could find money for this. Or hire me to run the office teaching it. But we really need to do a better job. And so at the time when I started on this, Lissa McInerney was my chair at University of Rochester, and she's the one who got me taking formal coursework. And Al Mushlin was the director of the clinical outcomes course that got me interested in Delphi. And so I'm very grateful to them for having helped down this path. And what I really hope that we can do is generate much more interest in real well-written, well-evidenced, or well-done consensus guidelines for clinical practice in metabolism. So, so now that I've blown all your brains, it wasn't as bad as a pathway. There were no pathways in this slide, in this talk.